Speaking very briefly on controversies to consensus in the management of hypertension. We keep talking about hypertension day in and day out. We'll keep it brief today. Outline will be one bit of hypertension, the Indian scenario. Couple of words on blood pressure measurement, ambulatory blood pressure monitoring, how it is important. Some recent guidelines, what they tell us and what are the changes in it. And a couple of new trials which have opened our eyes on what should be done and what the new guidelines are likely to be. And something on chronopharmacology, about how we prescribe drugs and how it should be done, and a couple of slides on conclusion. Now, Indian scenario, the prevalence according to available data. We know in India, we always said data is lacking, and we all do a lot of hard work, but as far as publishing is concerned, we seem to lag behind the rest of the world. And we probably see 5 times or 10 times the patients some of our colleagues in the Western world would be seeing. But somehow we do not really have very authentic data. But what we have, it's said that prevalence in India is about 29%, rural 27%, and urban 33%. And over the last 50 years, there has been a steep increase in the prevalence of hypertension, both in the urban and in the rural populations, like all lifestyle diseases. Now, prevalence of hypertension, says it's urban is some 33%, somebody's forgotten. And awareness status is about 40% urban and 25% rural. Those are being treated is again much lower in rural compared to urban. And worst part is people who have hypertension, they say is only 20% of the urban population is actually well controlled compared to the rural population. Comparative worldwide figures for this are about 30%. So we are definitely lagging behind by more than 50% of how our patients get treated and how much are under good control. Now, despite all the efforts, the level of awareness about blood pressure is still low in India, which is also evident with lower proportion of patients being achieving optimal control. As I said, it is low. It is actually very low. Only 10% of the rural population has their blood pressure under good control. Now, blood pressure, we all know, was first, this was not put in the quiz, otherwise maybe one of us could have got it. And Stephen Hales was the first to measure the blood pressure. He did it with his horse lying down, a brass tube inserted into the carotid, connected to a 12 feet long glass tube. And interposition, the junction was made with a trachea of a goose. It must have been one of the very early innovations, I'm sure. And from that we have come a long way. It took almost 100 years before somebody else thought how to do it, and a mercury manometer was used. All this was of course invasive and not very easy to put into practice. The actual sphygmomanometer was introduced in the 1890s, and a sphygmomanometer means a pulse pressure monitor. And what it consists of is not very different to what we use now. A mercury column, a rubber sleeve to be filled with air, and a squeeze back to inflate. So that is what a sphygmomanometer has been for about the last 130 years. Now, this is a very important statement which was made by one of the authorities on hypertension, Kaplan-Meier. Now, he said the measurement of blood pressure is the clinical product of the greatest importance that is performed in the sloppiest manner. I think this is something which we all should think about each time that we measure the blood pressure. Now, to measure the BP, of course, there are guidelines, and all of us have been reading and studying about it right from our MBBS days. And what the Indian guidelines say, which was published a couple of years ago, was there should be an average of 3 readings taken 2 to 3 minutes apart. Patients should refrain from smoking or drinking tea or coffee or exercise for at least 30 minutes before the measurement. Patients should be asked to sit for at least 5 minutes in a quiet room, and it can be done either in the supine or in the sitting position. The patient's arm should be fully bared and supported the level of the heart. We very often see, especially in the outpatient, patients come with sweaters, jackets, and blood pressure is measured above that. That is extremely wrong. You can get wrong readings because of that. And at least in the initial part, blood pressure should be measured in both the arms, and whichever is higher, usually the right one is higher, that should be used as the actual reading. Now, there are some few key techniques that should be done. Let us not go into a lot of detail in this. One thing, they should rest for 5 minutes. They should be seated with their back supported. The cuff should be at a mid-sternal level. Use the correct size cuff. The center of the bladder, which is marked in many of the newer instruments, should be over the brachial artery. Deflation should be slow, about 2 millimeters per second, or some people say 2 millimeters per heartbeat also. No talking during measurements. Okay, a lot of people keep talking or keep asking the history why the blood pressure is being measured to save time. You put an automatic instrument on the patient's arm and you keep talking to the patient asking for the history. If you look here, while talking, the blood pressure can go up almost by 15 millimeters, which is obviously going to give you an extremely wrong reading. Okay? And if your first reading is high, then that should be ignored and use the other two readings for the actual measurement or for treatment. Now, all of this requires between 8 to 11 minutes, which is close to impossible in a busy practice. But that is how life is. What is ideal, you can never do it. Now, ambulatory blood pressure monitor gives us a 24-hour blood pressure. It is useful. It will measure blood pressure during daytime, nighttime, through sleep, etc. And it is said to correlate closely with hypertension related end organ damage far better than office blood pressure readings. So now a lot of studies are there which have now definitely shown that ambulatory blood pressure is useful, and you can identify non-dippers. Non-dippers are those who do not dip their lights during driving. They are not the non-dippers. Non-dippers are those who do not dip their blood pressure during sleep. During sleep, the blood pressure is meant to decrease anywhere between 15 to 20 millimeters systolic, and those who do not dip their blood pressure during sleep have a much higher risk for cardiovascular morbidity and mortality. Indications: newly diagnosed hypertension, borderline hypertension, what everybody likes to say is white coat hypertension. Whenever I measure the blood pressure and tell somebody your blood pressure is high, they come back and tell me, no doctor, this is white coat hypertension. I measure the blood pressure at home, it is normal. But if you see, they already have hypertrophy on the ECG, they have hypertrophy on the echocardiogram. So finally we have to tell them this is much more than white coat hypertension. So such patients, if you put them on ambulatory blood pressure, you can then convince them that they require treatment. Isodiatic systolic hypertension, those who are suspected to have nocturnal blood pressure. When do you suspect this? When very borderline blood pressure, they are already showing end organ damage. That means they probably have elevated blood pressure during the night, or they are non-dippers. In such cases, they definitely require treatment. Those whom you suspect resistant hypertension. Hypertension of pregnancy is again important because even small increases in blood pressure in ladies during pregnancy, when most of them are in their 20s, is a very high risk of morbidity and mortality to the fetus. And those who have hypotensive symptoms, those who have symptoms of giddiness, etc., in such cases you can use ambulatory blood pressure. Now, European Society has given some recommendations which we should know. Awake blood pressure should be less than 130/80, and sleeping blood pressure should be less than 115/65. That means, again, as I said, about a 15 millimeter drop in blood pressure during sleep. And if they have a sleeping blood pressure of above 125, it is said to be abnormal, which normally we would not even think about treating. Okay, so these are average 24-hour readings of ambulatory blood pressure. Limitations: of course, it can be used for only one person at a time because they have to wear it for 24 hours. And it can be little demanding during sleep, during your work. You have something tied to your arm and carry a recorder in your pocket. It is not very easy to implement. Not many people like it, but it is extremely important as far as diagnosis and treatment is concerned. Of course, it is more expensive than conventional treatment because it is a wearable apparatus which has to be on you for at least 24 hours. Next, coming to a few recent guidelines. JNC came out a couple of years ago, again European Society and American Society of Hypertension. All of them come out with recommendations in the last 2-3 years. Now what is similar between all of them is, one is threshold for treatment. Most of the treatments say 140/90, 140/90, 140/90. Okay, so any blood pressure above 140/90 should be treated. Okay, the slight differences are JNC 7 says less than 60 years, and above 60 you can accept 150, whereas American Society takes it up to 80 years. That means even up to 80 years, the target should be 140/90. Okay, that should be the level at which you start treatment, and that is the goal you should try and achieve when they are on treatment. Next line is, there was a bit of controversy about beta blockers. JNC 8 does not mention beta blockers as first choice, whereas European Society and European Society of Cardiology still says beta blockers can be used as a drug of choice or a first line therapy. Initiation of true drugs or combination drugs now has become standard treatment. There are a lot of formulations available where you have 2 or 3 drugs in combination that are available, and any blood pressure 160/100 is an indication to start fixed combination so that they can be taken together and the compliance will be better. Indian hypertension guidelines, they say younger is less than 55, older say for those above 55. Okay, step 1 can be inhibitor or a beta blocker, and in the older people, we won't say elderly because they're not even senior citizens at 55. Slightly older patients, you can use a calcium channel blocker or a diuretic. This is one of the very old synonyms used, but Indian guidelines still stick to that. Step 2 should be you add one from the other group. Step 3 is you add C plus D. That means they should by this time be on all 4 drugs. And step 4, those who are resistant, then you can either add an alpha blocker, a spironolactone, or any other diuretic. Okay. Now, fixed dose combinations, which are also known as polypills, it is, as I said, it is important. And the guidelines now say blood pressure is above 160/100. Combination drugs are where 2 or 3 drugs available can be used. And all new guidelines say that chlorthalidone is now a diuretic of 5 as compared to hydrochlorothiazide. Till a few years ago, hydrochlorothiazide used to be the diuretic of choice, but now that has now been changed to chlorthalidone. Now beta blockers, as we said, has gone a little bit in the background. The JNCA does not recommend beta blockers. All this started a few years ago, at least about 8-10 years ago, where atenolol in 2 studies, the LIFE study and the ASCOT BTLA study, showed that the protective effect of atenolol, both for cardiovascular mortality and stroke, was not as much as ACE inhibitors and calcium channel blockers, because of which atenolol, which was at that time the maximally used beta blocker for hypertension, was taken out of most of the recommendations. Whereas the newer beta blockers, especially nebivolol, has come back in a big way, and now there are recommendations not from these societies, many other people or experts, which say these 3rd generation vasodilating beta blockers like nebivolol can now be used as a first. Now we'll just go to 2 recent trials. The SPRINT trial, which basically compared 2 types of therapy: intensive therapy, where you want the blood pressure down to 120, or standard therapy, as I said, where you would aim for blood pressure at around systolic blood pressure around 140. Now here you will realize that people have almost stopped talking about diastolic blood pressure to major extent now. Most of the trials now talk about systolic blood pressure. When we were students, we all used to talk about diastolic blood pressure, more important. Now that has almost gone out of the equation. We talk about systolic blood pressure targets. Okay. Now this study compared 2 arms of therapy, and the intensive arm definitely had about 25% lower primary outcome events were heart disease like stroke, acute myocardial infarction, and heart failure, and all cardiovascular death. So you'll see that all of about 25% lower when you try to bring the blood pressure down to 125. Okay. And the flip side of this was they also looked at the safety outcomes, whether 120 would be too low. Now, as expected, hypotension was about 2.4% in the intensive arm and 1.4% in the standard arm. So there was a higher hazard risk of patient developing hypotension or hypotensive symptoms, number one. Secondly, acute kidney injury, okay, measured as drop in glomerulofiltration rate, was higher in intensive arm, almost double, 4.1 versus 2.5. Now, this decline in GFR, whether it was just a harmless hemodynamic or whether it is a measure of worsening function, we do not really know. This is something which is a hypothesis. We do not know whether it will lead to worsening of renal function in the sprint conclusion was that the overall benefits of more intensive BP lowering exceeded the potential risk. And all the other treatment effects were similar. The only thing was we do not know whether small thing like hypotension symptoms, of course, they will be more, but whether drop in GFR to be significant in the long run is not well known. Okay. Now, what are the implications of this in our practice? Okay. Now, one thing is BP measurements are based on 2 or 3 average readings. It was measured by automated instrument with the patient sitting quietly in a room with nobody else present in the room, number one. Okay. And the way we measure blood pressure, we always measure it a little higher. So blood pressure measurement was something which they gave a lot of importance to. If sprint is applied without attention to proper BP measurement, substantial over-treatment, like I said, may happen. Because what we record blood pressure, it always comes about 10 to 15 millimeters higher than the way it is recorded in the sprint or the sprint trial. And other thing they say is, would you want to change your targets to 120 or less? Maybe yes, maybe no. But it is important to definitely keep it above 140 or as close to 120 as possible. Other couple of things from the sprint studies. One, chlorothalidone I mentioned. The drug of choice calcium channel blocker should be a amlodipine. Beta, as I said, was used much less in this particular trial. Another trial is the HOPE-3 study, where those with intermediate cardiovascular diseases were treated either with a placebo or a combination of hydrochlorothiazide and candesartan to see whether giving these drugs in intermediate risk normotensive patients would decrease their risk. This did not really occur. Cardiovascular death, MI, stroke was similar in the placebo and in the candesartan arm. Okay, so no significant difference between significant outcomes like total mortality or new onset diabetes. When this subgroup was broken up into 3 subsets: systolic blood pressure less than 130, 130 to 143, and above 143. Then in such cases, active treatment group had a lower outcome than the placebo. So those who have slightly more of borderline high blood pressures will improve by treating them aggressively with medications, whether it is ACE inhibitors and diuretics or calcium channel blockers. Okay. The comment from the authors was, our findings contradict that lower is better hypothesis. Now this is the controversy. One study says that lower is better, you should try and reach 120 if possible. HOPE-3 says if it is less than 140 it is enough, 120 may or may not be necessary. Now those with diabetes, that always special mention is mentioned about diabetes in most studies. In the ACCORD BP study, they found that those with intensive treatment had a blood pressure about 120, but there was no difference in outcome. Okay. fatal outcomes and non-fatal outcomes did not increase with the blood pressure coming down to 120 in a diabetic population. So the goal of blood pressure, we'll stick to what we initially said, 140/90 for everybody, and if there is significant albuminuria, then you should try and bring it down to 130/80. Okay, so this is now standard recommendations all over the world, all subsets. Those with significant proteinuria or renal dysfunction should have blood pressure less than 130/80. All others it should be 140/90. Next controversy is that when should you give it? Should you give the drugs in the morning or evening, this single drug combinations? As of 2011 Cochrane review, there was no definite mortality benefit or cardiovascular event benefit giving it either morning or evening. Now there are two major trials which are looking at this. Treatment in morning versus evening, that is known as the time trial. Similar is the IGIA trial, where they want to look at points to see whether fixed drug combinations given in the morning is better or given in the evening is better. Drugs, antihypertensive drugs given in the evening, as long as they do not contain diuretic, have shown to decrease ambulatory blood pressure much more than the drugs given in the morning. The general consensus or the practice has been that blood pressure is higher during the day, so you give all antihypertensives in the morning. But some studies have shown that antihypertensive therapy given at night or in the evening brings down the ambulatory blood pressure much more. But there are no data to say that this improves any cardiovascular mortality or hard endpoints. So in conclusion, hypertension remains a condition of public health importance in India. Methodology to measure accurate blood pressure should be given due importance. Okay, this is an important take-home message. We should spend some time in measuring the blood properly. Ambulatory blood pressure is a important tool, and we use it for various conditions that we mentioned. Although recent trials have provided useful information for lowering BP, further usual goals of BP goals should be followed. You should try and keep it to 40/90 and 130/80 for those with nephropathy. Don't try to bring it to 120/80 unless you have to. Okay, unless they have renal disease and patient is not having hypotensive symptoms, because we know that symptoms can get worse and renal function measured as GFR can drop. Goals can be lowered further in some special situations. We saw that. Choice of drugs for controlling blood pressure should be individualized, and evening dosage of antihypertensives can be advised safely. And lastly, that we have to come out with our own trials. We keep talking about it, but actually we have not done anything about it. Thank you very much.